Hello, everyone. I'm Amelie McFadyen, Chief Executive Officer of HPV Global Action, and I am pleased to serve as moderator for today's program. I would like to thank you all for joining us for today's continuing medical education webinar presented by HPV Global Action and the Consortium for Infectious Disease Control. Today's presentation is entitled, "Is the elimination of cervical cancer possible in Canada without real equity in access to HPV-related prevention services?" We are very fortunate to have three international experts, Dr. Ivan Litvinov, Laurie Smith, and Dr. Aisha Lofters, to provide this very important presentation. Just a note that Dr. Litvinov's portion of the presentation is a pre-recording, and he will be trying to connect with us later on for the Q&A portion at the end of this webinar. I would also like to thank Hologic and Merck Canada, whose support has enabled this webinar to be provided at no cost to the participants. In today's webinar, Dr. Litvinov, Laurie Smith, and Dr. Aisha Lofters will address the learning objectives that you can see on the screen currently, to review the distribution of burden of HPV in Canadian populations, list examples of populations and health inequities in Canada, overcoming challenges in reaching populations who do not have equitable access to HPV prevention, and examples of adapted HPV prevention measures for people who are immunocompromised. Please note that the webinar is being recorded, and the recording as well as all the PowerPoint slides will be made available following the webinar. These will be archived on both HPV Global Action and CIDC website. You can see the addresses at the bottom of the slide currently. The recording as well as other recording from other webinars and a number of useful resources can also be found on both websites. Additionally, you can join the Canadian HPV network by completing the contact form online on the CIDC website. A few administrative notes. You can hear the audio via your computer speakers. All participants have joined the webinar in listen-only mode. If you wish to ask a question, you can do so at any time during the webinar, and you can type it in the question panel and click the send button. The questions submitted during the webinar will be saved, and all or as many as we can will be answered following the presentation during the Q&A portion. If we're not available to answer all the submitted questions, we will attempt to ask the presenters to answer them by written. And for what we were able to do, we will put the questions and the answers on both the CIDC and the HPV Global Action website. Once again, you can see the websites at the bottom of the slide. Finally, we hope that all participants will complete the webinar evaluation. On this slide, you can see the link for the brief evaluation survey. If you registered and logged in for the webinar with your own email address, you'll be sent an email following today's webinar with the survey link. Otherwise, you can take a moment to take note of the address, and we will show it again at the end as well. Our first speaker is Dr. Litvinov. Dr. Litvinov is the Director of the Division of Dermatology of the Faculty of Medicine and Health Sciences of McGill University. He earned his PhD degree in cellular and molecular medicine at the Johns Hopkins Schools of Medicine in Baltimore, and his medical degree at McGill, completing dermatology residency training at McGill University Health Center.
Good day, and thank you very much for the opportunity to present a topic that is near and dear to me. Today we're going to talk about understanding the burden of HPV in Canada and discuss available preventative measures to prevent warts and skin cancers and various other cancers caused by the HPV. I'm going to speak from a dermatologic perspective, as I'm the Director of Dermatology at McGill University and McGill University Health Center and President of the Skin Research Group of Canada. So I see these diseases, warts and various skin cancers caused by HPV quite a bit in my clinic, and here you can see a happy patient receiving vaccination from this virus. So this virus affects the Canadians a great deal. There's about 50,000 genital warts that we diagnose annually. And of course, in addition to the tissue destruction by the wart, a lot of psychological impact is taking place on the patient by the genital warts. But then there's all these other cancers that we diagnose and treat that are related to the HPV that do not take into account skin cancers that I'll show you that I think the HPV is playing a role in. So oropharyngeal cancers, cervical cancer, vulvar cancer, vaginal cancer, anal cancer, penile cancer. None of those things are nice, and I don't wish it to anyone. And we can prevent these cancers by receiving vaccination, as we will discuss. So every year, we have about 1,200 Canadians dying from HPV-associated cancers, and here's the breakdown for those malignancies. Important things is we are actually being quite successful in treating cervical cancers in women. As you can see, the women are vaccinated, and so the incidence of cervical cancer is going down. But the incidence of oropharyngeal cancer is on the rise. And what this figure shows is that oropharyngeal cancers are mostly occurring in men. So we need to do more for the men in terms of vaccinations against HPV. So you can see, and in fact, we know that those curves crossed, and there's now much more oropharyngeal cancer compared to cervical cancers. Other cancers are more or less remaining at about the same way. So how does someone knows whether the given cancer is caused by HPV or not? So here is some staining that I present to you, which is routinely done by a pathologist for a given cancer. And so it starts with staining for P16. So when a pathologist stains for P16 and it's positive, they know that this is HPV, and then they can do a molecular in situ HPV test, looking at for nucleic acid to confirm that it's really caused by HPV. So which cancers are caused by HPV? Well, anal cancer is very high, 90%. I put right after it sort of in between skin, and I'll show you that it's probably very, very high caused by HPV, followed by oropharyngeal cancer, penile cancer, oral and laryngeal cancers. But you can see all of them have substantial impact by HPV, and particularly carcinogenic subtypes 16 and 18. So what do we know about skin cancers? Well, this is a cancer that is quite interesting. It could be a poster child for understanding the role of HPV in skin cancers. So this is epithelioma cuniculatum or carcinoma cuniculatum. It starts as this fungating wart, which is neglected, and gradually this wart becomes actually an invasive squamous cell carcinoma, as shown here. And so essentially, it's always well differentiated. It doesn't metastasize, but it can cause local destruction and invasion of underlying tissues. And every time we look for HPV in this cancer, it's there. So these subtypes have been strongly implicated. And we do believe that HPV, because it starts as a wart, is essentially driving the carcinogenesis of the skin. What about other cancers? Well, in fact, squamous cell carcinomas are second most commonly diagnosed cancer. Every year in the United States, there's over 700,000 squamous cell carcinoma cancers. And based on what the evidence that we have, we think HPV contributes to those cancers as well. Here's a picture of squamous cells on the forehead and on the forearm. So when people have looked at squamous cell carcinoma versus normal skin and likelihood of finding HPV there, we can see that the entire curve is shifted here to the right. In other words, when compared to normal skin, we're much more likely to find HPV virus in the cancer and not the normal skin. Furthermore, when we look at squamous cell carcinomas in immunocompromised versus immunocompetent individuals, again, we see a shift of the curve to the right, where we're basically essentially seeing much more HPV in immunosuppressed HCCs as compared to SCCs coming from patients who are not immunosuppressed. So the role of HPV in squamous cell carcinoma remains to be elucidated, but we really believe that it is a co-carcinogen together with a sun. We also know that normal skin of an individual is actually littered with HPV. They've done those metagenomic analysis of normal clinical appearing skin, as well as samples from vagina, mouth, gut, etc. And you can see that normal skin has 61% prevalence of HPV, followed by vagina, mouth, and gut. And then when we look at the subtypes that you find in normal skin, of course, you see some that are listed in red. Here you can see the red box of all the subtypes found in skin, and you can see the ones that are listed in red are cancer-causing ones, HPV 18, 45, there's overlap with the mouth, etc. But this message is just to say that normal skin is not normal. Normal skin in most individuals carries HPV, cancer-causing subtypes. And so, therefore, the emphasis on prevention of HPV, not just for genital warts, not just for the cancers I showed you, but also for the skin. So what do we know? Well, we know that Gardasil 9 is indicated initially men 9 through 45, but now the new recommendation states that there is actually no age limit for administering Gardasil 9 to individuals. In 2022, Health Canada gave a new indication for prevention oropharyngeal head and neck cancers caused by HPV. We know that it's preventing anal cancer, genital warts, anal intraepithelial neoplasia, and I would argue that this vaccine is very important for the prevention of skin cancers, which is highly prevalent. So this is again a summary of the burden of HPV, which doesn't take into account skin cancer. And so let's talk about the HPV vaccine. So as we highlighted, it is important to emphasize vaccination in males. Why? Because when males develop HPV, it doesn't actually produce immunoconversion. So immunogenicity of HPV infection differs in males than in females. Males are 4 to 10 times less likely to seroconvert, meaning develop immunity against HPV. When men do seroconvert, the antibodies that they produce are actually not effective to prevent future HPV. As a result, males acquire HPV infection at a steady rate. And here's a slide to that, where you can see infection due to any HPV in males or high-risk HPV. And you can see that once males become sexually active, they acquire this infection at a steady rate, meaning they don't develop immunity from prior HPV disease. When they develop the antibodies, you can see that the chance of seroconversion is very, very low, only here from 2 to 12%, and that's indicated in this graph here. And it takes long time, over 36 months. And essentially what we're going to show here in this graph is that these antibodies are not effective. When you look at the individuals who are having the antibodies, so seropositive, versus individuals who do not, you can see that they continue to acquire infection at the same rate. So essentially, the take-home messages here are this. Males do not seroconvert. When they do, they produce antibodies. It takes a long time to do so. And these antibodies are not protective against future HPV. So what should we do? We should really focus on males. We know that especially the middle-aged males, right now, most of them are not vaccinated. So first public HPV vaccination program was targeting females, and it was in 2007. By 2010, all provinces had vaccination for school-age females. First public vaccination program for males was 5 years later, in 2012. And only by 2017, all provinces established vaccination for school-age males. There's an impact of COVID, obviously. You can see, from 2020, 2022, where probably a lot of people were not vaccinated. And we know that prior to the implementation of the public vaccination for boys, 98% of people vaccinated were females. And despite gender-neutral vaccination, in 2015 in PEI, one study showed that grade 6 girls were 1.5 more likely times be receiving the vaccine than boys. So we really need to focus on vaccination for males, not only for prevention of the HPV warts, but also to prevent various cancers, and particularly oropharyngeal cancer. So this is the latest NACI recommendation, National Advisory Committee on Immunization, and we can see that vaccine is indicated. Vaccine is indicated for males 9 years and up, and there's no upper age limit. And we know that the vaccine is working. We know that it is producing immunity. There's been a number of studies, including middle adult men trial, that produced data saying that males do develop antibodies against these pathogenic subtypes, HPV 6, 11, 16, A18, at actually the rate which is comparable to females. We know that the vaccine is very safe, and there's very, very few side effects, and you can see most of them are just related to injection site reaction, headache, nasal congestion, etc. So, and we know that it works in females, which makes us believe that once it's effective and producing immunity, it will be working in males. So here is a New England Journal of Medicine study out of Sweden that's showing that when you vaccinate females, you reduce incidence of cervical cancer by 63%. And when you talk about bang for the buck, you get the most bang, the most effect if you vaccinate people early. So it's critical to vaccinate people before the age of 17. You can get 88% reduction in incidence of cervical cancer. But even if you vaccinate at an older age, 17 to 30, you get more than half of a reduction of cervical cancer. So you substantially reduce the risk of invasive cervical cancer. And based on this data, we believe that once we're able to achieve effective vaccination and immunogenicity in males, we will be able to reduce some of the other cancers that are now taking hold in this population. And as I showed you before, while we're doing well in cervical cancer rates, it's going down. The other cancers, in particular oral or pharyngeal cancers that are much more prevalent in males, they are on the way up. So, and the focus really should be on men, middle-aged males. So in conclusion, here's the list of cancers that we believe are strongly driven by HPV or where we find HPV positivity. Incidence of penile, oral pharyngeal, or oral cancers is stable, but oropharyngeal and anal cancers are actually on the rise. And men, right now at the middle-age stage, remain significant risk and are under-vaccinated for HPV. HPV vaccination also, as I said, based on the evidence we have, may prove to be very effective in preventing some skin cancers, and particularly cutaneous squamous cell carcinomas. And that's the second most common cancer in Canada and in the United States. In the States, they diagnosed 700,000 cases of it alone. And non-covalent vaccine is effective in including seroconversion based on the evidence in women, but also effective in men, reducing HPV VARs and malignancies. So my take-home message as a dermatologist is we're very used to doing this. Please avoid the sun and use the sunscreen. But we also should be giving our, especially males, middle-aged males, this recommendation. Please receive HPV vaccine to prevent various cancers and skin diseases. And of course, if for anybody who is a physician, exposure to HPV is very common because we do multiple procedures. So for healthcare professionals, nurses, physicians, it is critical to be vaccinated to prevent HPV warts and cancers. So I ask you to promote this public health measure, vaccination, and you will not be doing this alone, as there are many other societies, as highlighted here, who also strongly promote HPV vaccination. With this, I want to thank you for your attention and wish you a pleasant day.
Okay. Just before I go on to introduce our next presenters, I just wanted to mention, I think the pre-recording worked for most from what I could see, but if for some reason you couldn't hear properly or see properly, just know that the pre-recording as well as the rest of the presentation will be made available on the CIDC and the HPV Global Action website, so you can go back and listen to anything you may have missed. So our next speaker is Laurie Smith, and we're in co-presentation with Dr. Aisha Lofters. So first, Laurie Smith is the Program Manager of the Global Control of HPV-related Diseases and Cancer Research Program at the Women's Health Research Institute, BC Women's Hospital. She has over 15 years experience with HPV-related disease research, particularly focused on primary and secondary prevention of cervical cancer. Dr. Aisha Lofters is a scientist at the Women's College Research Institute, adjunct scientist at ICES, and an associate professor in the Department of Family and Community Medicine at the University of Toronto. Dr. Lofters is also the Provincial Primary Care Lead, Cancer Screening at Cancer Care Ontario. Her research program focuses on improving quality of care in cancer screening and prevention, particularly for populations that experience marginalization. Welcome, Laurie and Dr. Lofters.
Whoops, sorry, I was on mute. Thank you very much. We're very excited to be here and presenting. We'll be speaking to you about equity in access to cervical cancer prevention measures. But certainly, I think much of what we'll be talking about is applicable to other types of HPV-related cancers and other health conditions in general. This is just our conflict slide, just our conflict declaration. And then let's dive into it. So I think one of the things that we really want to emphasize when it comes to cervical cancer is that cervical cancer is almost entirely preventable. A lot of people don't realize that. But through the combination of primary prevention with HPV vaccination and secondary prevention with cervical screening, this disease really can be eliminated. Primary prevention, meaning preventing it before it even occurs, and secondary prevention, meaning catching things very, very early. Despite the fact that it can be almost entirely prevented, this disease still remains a global burden and is actually the 4th most common cancer among women worldwide. It's also very much a disease of inequity. So in 2018, there were about 500,000 cases globally and over 300,000 deaths, but 90% of those were in low and middle income countries. So very much a condition of imbalance based on societal factors. This is a graph to just illustrate that point. This is a visualization of the age standardized incidence rate for cervical cancer in 2018. So looking at in that calendar year, where did we see the highest incidence of cervical cancer? And you'll see looking at the bottom left that the darker the country is, the higher was the incidence rate of cervical cancer. You'll also see that there's a very clear pattern associated with the income of that country. So we see a very high burden of cervical cancer in sub-Saharan Africa, in some parts of Asia and South America, and a much lower burden in places like North America, Australia, and Western Europe. Just showing how much income and inequalities really play a role in cervical cancer incidence. Now, because of the fact that cervical cancer can be almost entirely prevented, the World Health Organization has really taken up this global call to action for all of us. So in May of 2018, the WHO announced this global call for action to eliminate cervical cancer, and in August 2020, formally adopted a global strategy to do so. This is just a quote from the Director General of WHO, who says, through cost-effective evidence-based interventions, including HPV vaccination of girls, screening, and treatment of precancerous lesions, as well as improving access to diagnosis and treatment, we can eliminate cervical cancer as a public health problem. This is a call to action to all of us around the world, and certainly here in Canada as well. So the WHO global strategy to eliminate cervical cancer goes a little bit deeper to talk about the fact that we really have this vision of a world where there is no cervical cancer, and setting a concrete threshold of 4 per 100,000 women per year. So that number, if we can get below that can be considered elimination as far as it being a public health problem. They also set specific targets that must be met by 2030 for countries to consider themselves on the path towards elimination. So this is 90% of girls being fully vaccinated with HPV by age of 15, 70% of women being screened with a high performance test by 35 and again by 45, and 90% of women who are identified with a cervical disease receiving treatment. These are global targets, so in countries like Canada, we need to be setting higher and stronger targets because we've reached some of these goals already. So for example, we do more routine screening than just once at 35 and once at 45. And we also know that vaccination among boys is quite common now as well. So I'll pass to Laurie.
Dr. Lofters did a great job of showing us the global burden of cervical cancer, and so we'll talk a little bit about cervical cancer incidence in Canada. We have an estimated 1,450 people in Canada will be diagnosed this year with cervical cancer, and nearly 400 will die. And although that doesn't seem as much of a burden as in some other areas, this is 1,450 people that are mothers, wives, partners, people that are working with young families. So this is an impactful disease. And the age standardized incident rate was estimated at about 7.1 per 100,000 in 2020. And as you saw on the WHO slide, the goal is 4.0 per 100,000. So we still have some work to do. And although Dr. Litvinov's slide showed that there was a decline in cervical cancer that has happened over many decades since the advent of cytology-based screening, but it's plateaued. And so we still are seeing invasive cancer in our population. And this is a great quote from a paper in 2014 showing that cervical cancer will remain an important determinant of screening will remain an important determinant of cervical cancer inequality between socio-demographic groups, even in the vaccine era. So sorry, my slides are a little slow here. So when the WHO released their strategy for the path to elimination of cancer, other countries around the world also detailed their own strategies, and the Canadian Partnership Against Cancer also developed an action plan. And this was a comprehensive document and plan, and it is engaging partners across Canada to work together to eliminate cervical cancer by 2040. And it is also anchored in 3 pillars as the WHO one. And the first priority is improving HPV vaccination rates by 2025, 90% of 17-year-olds will be fully vaccinated. Priority 2 is to implement HPV-based screening, and by 2030, 90% will be screened with HPV. And as Dr. Lofters showed, there was the goal at the WHO strategy is 70%, but because we are at 70% in many cases or places across Canada, we do need to increase that to reach the elimination goals. And then the third pillar is that to improve follow-up of abnormal screening results, and by 2030, 90% of people with an abnormal result will have a treatment pathway in a reasonable amount of time. And the action plan is much more detailed about each of these strategies. These are just some of the highlights. So, an issue of health equity. So what is equity? Equity is the absence of avoidable or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. And this is the WHO definition. Equity is achieved when everyone, regardless of various factors, has equal opportunity to access services and achieve their best health. So inequity is when there is systematic unequal access to high quality healthcare based on social conditions. And we highlighted remediable here because these are conditions that can be prevented, or something can be done about them to ensure that there aren't differences in health based on people's social conditions. And how is equity and cervical cancer related specifically? Well, most who develop cervical cancer in Canada, and quite frankly everywhere, are never or under-screened. Not everyone, but this is the majority of people who develop cervical cancer. And there are many, many reasons why different groups are under-screened. But we need to address these inequities, and it's critical to achieving the goal of elimination of cervical cancer. The status quo, which we currently have, will not decrease cervical cancer incidence any further unless we address these inequities. The good news is that programs today, really more than ever before, are designing programs and starting to think about these approaches and deliver them with a health equity lens.
So where is it that we see inequities in cervical cancer prevention, so in screening and vaccination in Canada? So we've listed several groups here on this slide, but I think what we want to emphasize is that there are many populations for a variety of systemic reasons where we see inequities that exist, and also to recognize that many people don't just have one singular identity. They might have multiple identities that we see on this slide and beyond that might affect the likelihood of cervical cancer screening. Certainly, though, in looking at the literature, we do see that there are disparities and inequities in screening when it comes to characteristics such as ethnicity, including Indigenous status. We also see this playing out based on geography, so people who are living in rural, remote areas having less access to cervical screening. Certainly for folks who are gender diverse or trans and non-binary populations, less likely to be screened, which can tie into both the lack of knowledge in a provider's point of view, and then even just the test itself can be quite gender disaffirming for many people. Even though in Canada we have a universal healthcare system, we still see clear socioeconomic gradients when it comes to cervical screening. So people who are living in the highest income neighborhoods having the highest screening, and then that going down in a gradient as the income in the neighborhood gets lower, despite there being no direct costs of cervical screening at this point in time. And then immigrants and refugees certainly tend to have lower rates of cervical screening than we see for folks who are Canadian born. And again, we do see differences even within the immigrant group as far as which part of the world that people are coming from. And then a cross-cutting group, which obviously can occur for people who meet any number of characteristics as well, but those are the history of trauma. The PAP test, which we currently use, is, it's a pretty invasive and intimate test, and this can be quite traumatic for folks who have a history of trauma, whether sexual trauma or history of trauma in the healthcare system. This visual comes from a study that I conducted a few years ago, and it's really just to illustrate how vast the inequities can be, even within a high-income country like Canada. So if you look at the two bar graphs on the left, that bar of 79%, this is looking at people who are up to date on cervical screening in Ontario, and 79% is pretty good. Still a ways to go to reach our targets, but is quite good. This group of women were born in Canada. They were less than 50, so in that premenopausal age group. They were living in the highest income neighborhoods, and they were in a primary care enrollment model. What this means is that they had a clear family physician that they could identify, that they had signed a form and formally enrolled with. And of that group of women, we see almost 80% being up to date. But that very small bar graph on the right, the green one, where we see less than 22% of women being up to date on screening, those were women who were immigrants to Canada, coming from South Asian countries in particular. They were over 50, so in that postmenopausal age group, although still eligible for screening, they were living in the lowest income neighborhoods, and they were not well connected to primary care. So we see almost a four-fold difference between these two groups, despite both of them being eligible for cervical screening. So we still have quite a long way to go to address the inequities that we have, even within our own borders. And why is this? The barriers to screening are multiple, and they occur at multiple levels. As we've broken them down here, so we've touched upon some of these already. So the individual level, things like history of trauma, sexual stigma. This test does have a connotation about sexual activity, and lack of knowledge. The test itself, as we've mentioned, is intimate and invasive and uncomfortable, which for some people is a minor annoyance, but for other people can really be an insurmountable barrier. At the practice and provider level, certainly we all know primary care is struggling right now across the country. So things like access to appointments, people able to get in the door to see their doctor. And then once they're there, are we creating safe spaces for them? And is there a trusting relationship so that people have time to hear about screening and make up their mind about it? And at the system level, of course, competing system priorities, things like pandemics and acute care issues, and then just access to healthcare services, and even thinking about how we approach delivery of screening, and are we really providing as many options as are needed?
So we've, sorry, the slides are, there's a bit of a delay for both of us, so forgive us. How do we address these inequities? So we haven't put all the possible approaches here, but there are some things that can be done to address inequities. And one is to develop innovative, targeted, culturally safe approaches, and these are required to meet the goals for elimination of cervical cancer. The one approach to cervical screening can no longer work, as we've seen, and so we need to think about new ways and targeted ways to develop these. Programs should design or consider designing comprehensive health equity plans. We've seen more of these in various health programs. These are plans that have a vision, specific targets, detailed strategies, and an evaluation plan. Without evaluating if your program works, we're not going to, you won't know if it actually was successful. Again, the one-size-fits-all strategies don't work, so being multi-pronged and having options to offer people is one way to address inequities. Ultimately, strategies really need to be acceptable to the target population and designed collaboratively with target groups. We've had success in using community champions and working with them to help design strategies. And ultimately, investing in equity is really important, and we can't emphasize this enough. And investing in time and resources and building that program to develop and design the health equity plan, that investment is important. So what are some facilitators of cervical cancer prevention? Increasing knowledge and awareness. A lot of people or different groups may not be aware of the need for cervical screening or how often it occurs or how to access it. designing culturally safe approaches, and these can be designed when we are working with the communities and groups to help ensure that the approaches are culturally appropriate. Flexibility in program and design approaches, and I'd also add there some sustainability, but having that ability to be flexible when the programs are designed. Again, involving the target demographics in the design of the approaches is really empowering individuals and making it people-centered and patient-centered. And where possible, integrating services. And what we mean by this is sort of bundling things together. So when STI screening is offered, that's another place to also offer cervical screening, or when mammography is offered, offering cervical screening at the same time, making it accessible and easy for people to access these services. And innovative approaches. With HPV-based cervical screening, we actually now have the opportunity to design innovative approaches. And one of these approaches is HPV-based self-collection. This approach really has the opportunity to address many of the barriers that we've talked about. So with the traditional approach to screening with the pap smear, a person needs to go see a healthcare provider at a clinic. With self-collection, the sample really can be collected anywhere by the person. It can be done in their bathroom, at a community center, at a clinic. It doesn't have to be done at a clinic's or a healthcare provider's office. The speculum exam is invasive for many people, and also with the pap smear, a sample of cells is directly required from the cervix. With self-collection, the person can easily collect the sample vaginally themselves. A sample of cells from the cervix is not required with HPV testing. The pap smear has lower accuracy, and we now know that HPV testing can identify cervical precancer earlier and better than the pap smear, and with self-collection, it's also safe and painless for people. We included this graphic as an excellent example of a visual that just really helps show how self-collection can address a lot of inequities and how this graphic can appeal to many different groups. We really like the hashtag self-care. It's showing how important cervical cancer screening is and the goal for elimination. So we just wanted to show that as a great example. And then in conclusion, just to summarize and leave you all with some highlights of how to address inequity with cervical screening, starting with the patient and the community voice to understand the barriers. If we don't understand why people aren't accessing screening, then we can't address how to change that. And again, investing in all caps, investing in design of programs with a health equity lens. And recognizing the role and expertise of community in co-designing solutions, so that the collaboration and partnership is important to addressing inequities. And then again, multifaceted, multi-level targeted approaches that again are sustainable and flexible are the key to helping address some of the traditional barriers and achieving more equity in cervical screening. That's it for us, so I'll hand it back over to Amelie.
Thank you very much to both of you for providing this very informative presentation. That was excellent. If you have any questions, I invite you to type it into the question box and send them in. We already had quite a few come in, so I will start the Q&A, but you can still submit questions throughout the Q&A portion. So for the first question, you mentioned a few times investing in inequity. Who exactly should be making these investments?
I think that could be a number of different people. It doesn't have to just be one group, but for sure, it could be government, it could be federal government, provincial governments, program planners, healthcare providers. Maybe I think this is a sort of a multifaceted approach that all should be investing in equity, because you can't solve this problem with just one group or one approach. So it needs to be an all-encompassing investment.
Thank you very much. Someone is wondering, why are not all provinces offering self-screening, and when will this happen?
I can comment, and perhaps Laurie can chime in too, because different provinces certainly are at different places. I think the first step before we can really implement HPV self-collection is to implement HPV screening. So many provinces right now, I think almost all provinces right now are still using the PAP test for routine screening. So I think the first step is to make a switch over to HPV screening, which many provinces are in the planning and preparation, some implementation stages of doing. But certainly I think once we have HPV screening in place and all the systems in place, and then bringing in HPV self-collection is key, as has happened in other parts of the world, such as Australia and some countries in Europe.
Yeah, and I could add to that as well. In British Columbia, we're doing several preliminary or pilot projects and research studies with self-collection to see how acceptability and feasibility in different communities. And this BC cervix screening program is running a provincial pilot on self-collection amongst various groups, the under-screened, never screened, in addition to people who are routinely screened, to see how feasible this approach is. And just to add to that a bit about the routinely screened, as we have gone through the pandemic and there is a healthcare provider crisis here in BC right now as well, I think there are new groups that can face inequities in cervical screening. And so with self-collection, it can also just help address some of these other barriers. But I agree with what Dr. Lofters said, is that we need to get HPV-based screening across Canada as at first, or at least in conjunction with self-collection.
Perfect, thank you. I have a few questions that have come in around this point, so I'm summarizing a little bit. But seeing the cost of the vaccine, how can healthcare providers keep promoting vaccinations to populations that are harder to reach or may not have the same income across Canada, knowing this cost associated to it?
So I think that's where the comment that Laurie made earlier about investment needs to come from all groups ties in. I think it's a very practical issue that if to encourage somebody to pay $400 for a vaccine if they don't have it doesn't make sense. So I think we need to look into what the government can do or what can happen to ensure that the vaccine is covered broadly for those who need it. But that's where that it can't just be one group or people who are perhaps in the middle of the hierarchy who are investing. It needs to come from the very top as well if we really want to eliminate cervical cancer and other HPV-related cancers.
Thank you. Does Health Canada have a plan to recommend and fund the HPV vaccine for middle-aged adults or others? And is there hope that HPV vaccine will become a routine vaccination for adults as well?
I can't comment on whether Health Canada or the federal government is planning to fund that. I think that would be wonderful. It would be great if it was publicly funded for all groups that needed it or all individuals that needed it. And again, this is another probably provincial, different provinces have different plans as well with regards to will it be routinely available for adults? Anyone that wants the vaccine can speak to their healthcare provider or find ways to access it. But yes, there is a cost if you haven't received it in the publicly funded program. It's an excellent question, and here's hoping that as, again, investing in equity or making equity a priority, that the cost of this can be considered down the road.
Thank you. And I think you're correct. It's a provincial jurisdiction for the vaccination. Do we have enough data to monitor our progress in addressing inequities in cervical screening? And what data do we need to do for this monitoring?
So certainly, I think this will likely vary province by province, but we do have data, I can speak for in Ontario, that we can monitor cervical screening, looking at immigration status and where people in the world are immigrating from. We can look at rurality. We can't look at income at the individual level, but we can look at it for neighborhoods. You can look at census data to look at neighborhood characteristics for a wide variety of criteria. So not just income, but instability and ethnic concentration, et cetera. We don't have much at the system level race and ethnicity based data, at least in Ontario, and I imagine the same is across the country. But we do have enough data where I think we have strong evidence for existing inequities, and we can use those data as markers as we are trying interventions going forward to be able to see if we're making system level improvements.
Just to add to that, Aisha, I noticed in the CPAC action plan, a couple of the goals are really to improve and enhance existing registries across Canada, vaccine and screening registries. So I think with this kind of investment in enhancing registries, that can help. If provinces do that individually, that can also help with the Canadian lens on how, as a sort of a marker of how we're doing.
Great, thank you. Speaking actually of the CPAC plan, a few people are asking if, in your opinions, the CPAC plan for the elimination of cervical cancer by 2040 properly takes into account these inequities.
There's quite a good section on addressing inequities. I think it's probably more than can be covered in that document specifically. It starts people thinking and asking questions and how they can do it. But as we talked about, how to address inequities isn't just simple fix. I think it just really does involve multi-level and involving all the target populations. I don't think each population that experiences inequities is in the action plan or discussed in the action plan. It wasn't the scope of the document, but they do a great job of starting that conversation and ensuring that equity is addressed in the elimination plan. I'm not sure if you had anything else to add to that, Aisha.
Yeah, the only other comment I would make is that, and again, and we'll keep reiterating this point, is that I think CPAC, I agree, has done a good job with bringing up equity in that report. I think now it is on policymakers to act and to take up recommendations to make that plan really come to life.
Mm-hmm. Thank you. Yes, I definitely agree with that last part you said. In terms of education for different populations, what is the best way to reach the hard to reach populations with education around the HPV vaccine or self-sampling or HPV testing, cervical screening, things like that?
So I think this is where the point of working with community can become really, really important, because I think there's the actual material, like the actual factual information about what is screening, what is vaccination, what is HPV. But depending on the particular groups that might be priority populations in a particular area, I think it's always good to start partnering with community to see what are the particular barriers, what are the cultural concerns, how can we frame this in ways that will be easily understood, who should be working with us to deliver the message as a trusted source. So I really think for those pieces, the facts is probably the easy part, but I think where the real work comes in is making sure that you're portraying it in a way that's easily understood and that's culturally appropriate, and doing so in a partnership model.
Thank you very much. I believe Dr. Litvinov was able to join, so I do have a question that was more specific to his presentation. If you're able to take it, Dr. Litvinov. Someone was asking, oh, hello. Perfect. Someone was asking, how come we are not hearing more about skin issues when it comes to HPV diseases?
Well, we do. I think we are discussing it. Of course, dermatology is a broad field where we have a lot of diseases, and we are talking about skin cancers arising due to HPV, and of course genital warts, and we treat them a lot. But I guess part of it is people are used to this, and everybody expects this to be part of life. So perhaps now that we have a vaccine which is effective, that could be an action point that we could raise to people and change the discussion, as opposed to this being fact of life, to the point where the warts can be prevented with this new vaccine.
Yes, thank you very much. Yeah, I think you're right that it needs to be communicated maybe better or in a different way to lay populations, specifically around the genital warts. Okay, so someone is mentioning that where they work, they have quite a few PAPs that come in through positive for HR-HPV in a pilot study, but then the PAP and VX are negative. And they're wondering, how does this impact the patient's psyche or emotional state, and what does a follow-up on this look like?
That's a great question. There's probably a lot going on there, but people can have HPV and not have site or cervical cell changes yet. HPV is highly prevalent, especially in people under the ages of 30, and it can be very transient. And so the HPV, usually with that combination of results, people are asked to follow up in a year or so. That's just in some of the experience, that's been our algorithm. But in the meantime, that does cause anxiety to people. But I think this is where that education and information helps to ensure people don't have that kind of anxiety, letting people know that anxiety is highly prevalent, it's very common, doing what we can to decrease the stigma surrounding HPV, letting them know that this is just a marker of risk, and that often it goes away on its own, and that a person will be followed up closely. Another thing that we often tell people is having HPV does not mean you have cervical cancer or will get cervical cancer. It just means that we know we need to follow you up a little bit more closely to see if that HPV goes away on its own or needs further investigation down the road.
Thank you very much. Is there any proven relationship between HPV and squamous cell carcinoma of the esophagus? I think is Dr.
Is that a question for Dr. Litvinov? Yeah.
Still online? Yeah. Okay, I think he may be having connection issues, so I'll move on to another question. Excuse me. Perfect. Quite a few people have asked if the Canadian labs, if all of them are able to run HPV self-collecting swabs, or will there be quite significant restructuration that has to happen before that can take place?
Laurie, I don't know if you can comment on your experience in BC. I think if we get to the point where, again, where HPV screening is the primary method that we're using for screening, that there should not be significant changes required at that point to bring in self-sampling, but perhaps you can comment on what's happened in BC.
Yeah, I think that's a great way to frame that, Aisha. It's really about, it's not just the self-sampling, it's the change that HPV primary based or primary testing would bring. So it is shifting from a sort of a manual process where cytotechnologists are reviewing slides to an automated process. So a change in a lab would be, it would be significant, but I think a lot of places across Canada are starting to plan for the implementation of HPV-based testing. It is coming. It's just a matter of when, and so self-collection would be a part of that plan for HPV-based testing, and just not necessarily just within the lab, but programmatically for an entire screening program.
Mm-hmm. And do we know, I mean, considering that self-sampling is not approved yet in Canada, I understand there's still some stuff that has to happen before programs can happen. But do we have an indication as to when that first step of being approved will take place?
That might happen. I mean, I could see it likely happening if we're talking about HPV self-collection, even at a provincial level, because as each province moves into HPV screening, so I think BC is really leading the way. Ontario is certainly planning to move towards HPV screening soon, and then to do similarly as BC, do a pilot of HPV self-collection. I think PEI is starting or has started HPV screening, and one would hope self-sampling would follow soon after. But I do suspect that it will happen at a provincial, the implementation at least will happen at a provincial level.
Perfect, thank you. On a slightly different topic, a few people have mentioned that one of the biggest barriers they encounter in their work is for immunization specifically, is the parents' refusal of the HPV vaccine for the children. and that a big educational promotion is necessary, but that there's a big stigma they notice around parents thinking it's a sex vaccine. So how do we go against that or around that?
I think there's, again, vaccine hesitancy is another, excuse me, big topic, but just to address that second part, there's a lot of data now showing that people who have been vaccinated against HPV early and young, kids in grade 6 or in elementary school, they do not commence sexual activity any sooner than other children do. So I think that is, that's information that we have out there now. It's not causing children to have sex sooner. It really is a vaccine that helps prevent HPV-related diseases and cancer. So I think if we can start to share that information more broadly, and also that is important for males and females, and vaccine hesitancy is probably a whole another webinar. But I don't know, Aisha, if you wanted to add a bit more to that as well.
Yeah, I agree. I think it really, as was part of the question, it really is going to take substantial education, taking time for people to truly understand what the vaccination, what it's about, what it does, what it doesn't do. Certainly I've heard that concern too, is that why are we starting so young? But I think to Laurie's point, to be able to point to evidence to say that it does not lead to younger age sexual initiation, and to be able to show the effectiveness of the vaccine is important. But again, I think, partnering with the community and understanding what are the particular concerns, what are ways that we can accurately, help to address those concerns will take time and investment, but it's worth it, right? If we can really educate people to understand more about the vaccine.
I also think that just as a society, if we really get rid of the stigma associated with HPV, some of these other issues would fall into place, that an HPV vaccine should be as acceptable as the polio vaccine or other vaccines that children get. So as soon as we can really address the stigmas that are associated with HPV, we may find that some of the other issues surrounding vaccination, screening, etc., take care of themselves eventually.
I wonder if I could comment. I mean, in dermatology, we've treated a lot of common warts, and this is always an opportunity for us to bring it up, because there is no stigma related to warts that are occurring on hands and feet. And so we highlight that there's many different variants, there's many different types, and it is painful to have this plantar wart on the foot, and we just don't want any warts in any locations, and therefore there's this opportunity for a vaccine to solve, presumably quite a number of those high risk and benign warts. So I think that could be a very useful way for us, especially in the patient encounter, to promote vaccines, not just to the patient, but also highlight that this is something important for the entire family.
Absolutely. Thank you very much. Unfortunately, this is all the time that we have for the questions. I know there are quite a few left, but as I mentioned previously, we will try and answer them in written and post them on the websites following this webinar. I would like to thank again all three presenters for their excellent presentation and for taking the time to respond to the questions from the audience. Greatly appreciated. It's been a pleasure working with all of you on the educational webinar. And once again, we very much appreciate the support of Hologic as well as Merck Canada that allowed us to bring this webinar to all of you at no cost. Please remember to complete the evaluation by clicking on the link in the follow-up email that you will receive shortly. Otherwise, you can also copy the link that you see currently on the screen. Please note again that the webinar has been recorded, and the video recording and the slides will all be available on both the CIDC and the HPV Global Action website in the near future. You can see both websites at the bottom of the slide currently. There are also a number of other resources and past webinars available on both sites as well. I'd like to thank everyone for your interest in the CIDC webinars. Please watch for an email notice regarding other upcoming webinars. Enjoy the rest of your day. Thank you very much.